Thank you, sir. At the outset, Professor Das and Vinita and AIOS. So we are going beyond the pressure. And for all of us who deal with children, we know that our job doesn't finish there because we have a lifetime to handhold and let them see better. So we know that it's a potentially blinding condition, and therefore our job doesn't end with IOP control in glaucoma or settling the retina if you're a VR surgeon or clearing the cornea if you're a cornea surgeon. Ultimately, you need to ensure vision. And preserving their long-term vision is the real challenge. So this neonate with CTT, with pressures control, your job is not done if you stop here. You have to push your cornea colleagues to do a transplant and then push them and hold their hands because they're going to come back to you with post-PK glaucoma maybe. So this is a desirable outcome. This is a 2-day-old, malnourished, underweight infant with bilateral severe PCG. So we admitted him, and he underwent pediatric consults. He had to actually have parenteral feeding because he was so underweight that he wouldn't even suckle. But anyway, we did the bilateral CTT whenever we could. It's clearer cornea 2 months down. He's at least started sucking a milk bottle now, and he's under pediatric care for systemic malnourishment. He was in hospital for a good 6 weeks or so. And at 18 months, you finally have this robust baby with a clear cornea, a healthy, normal child, right eye larger but not significantly myopic as yet, but under close watch for ocular deviation and amblyopia management. So your job doesn't end with just doing a CTT for a newborn baby that comes to you. Some stories can be much longer. So this 3-day-old PCG, for instance, who's come with left eye trab with trab at 5 days old and right eye at 1 month, and a persistent corneal scar in spite of pressure control. So you push for OPK, and once you push for the OPK, they come back to you with severe post-PK glaucoma, and then you put in the ADI. And 3 years on, the pressures are 14 on timolol, active patching in the right eye, and best corrected vision in this eye now 624, but we hope to get it down because she's just 3 years old as yet. Sometimes they come to us too late, and Parul and Shalini would empathize with this. The 16-year-old girl, your heart sinks because now the parents actually sometimes come and say, ab iski shaadi karni hai. I mean, you want to get her married now, and you know, what were you doing all this while? But there's no point in saying that. The right eye is atrophic. Don't write her off. Give her some hope. So she came to us with pressures of 30, vision of hand motions. The ultrasound showed a totally cupped disc, but we did go ahead with the trab with MMC, push the cornea service to do the OPK. She's now vision, counting fingers, 3 meters, and has seen more than she's ever done in her life before. So in spite of the challenges, if we don't give up, we can give them some hope. Sometimes an OPK is just not possible. There are constraints of tissue, there are constraints of reluctant pediatric cornea surgeons who don't want to do it because of a congenital limbal stem cell deficiency which happens in congenital glaucoma because of the severe stretching. So this PCG, 6 months old, severely photophobic. You can see she's hardly opening her eyes when she came to us here. Bilateral trab with trab done. The steamy cornea cleared, but the central scar remained. So she had severe congenital limbal stem cell deficiency also. So all we did was went ahead with an optical iridotomy. So we did do an optical iridectomies very, very often nowadays. And at least she's seeing, she's enrolled in school. Her vision though is 636 and 660, but we hope to handhold her as she's growing up. So even if the IOP is controlled, the cornea is clear, the disc is healthy, is your job done? So if you see this kid, for instance, operated at 9 months, and for some strange reason, because the cornea cleared and he was fine, he was lost to follow-up. And one fine day when he's about 4 years old, he came back to us, 10 pressures, cornea clear, disc healthy. Is your job done? But then you do a refraction and the myopia is like -21 in this eye, and these are the kind of glasses he was prescribed. So no child is going to be able to see like that. So we are fortunate that we have Professor Jagatram who allows us to push him, and this child actually, underwent clear corneal extraction for this, and actually he had to put in a -4 diopter. So on active patching with a near emmetropic eye now, even though the cornea is so large, you can see the glasses. These are glasses only for near in the right eye. His best corrected vision now is 612 on the active patching in the left eye. So your job really doesn't finish anywhere until you push and push for your children to see well, and that's what you're here for. Sometimes you need to make these clinical decisions, and ancillary testing is important. So you had this baby with a right corneal scar and a Peters abnormality basically. But there was a right central scar, and if you looked at this UBM, you know that this anterior segment is all right. So we've done an optical iridectomy there, and someday we'll push for an optical PK as well, but tiding over the vision till then. But the left eye, you can see that part of the lens is also there. So sometimes it's also prudent to know when to stop. So we're not going to touch this eye at all because this is not going to give you anything. Concentrate on an eye which has vision potential and take on from there. Remember, after having said all this, at the end of the day, the vision and eye and everything, the babies have a life. So this 2-day-old baby, again, with this clear thing in the middle, looked like a Peters, left was PCG, but to our horror, the UBM showed the Descemet's defect was so large that this lens was actually stuck and sequestered in the cornea. So then when you have something like that, we did try and get his lensectomy out. He did undergo surgery, but we landed up in an unsightly blind eye in the right, but the left eye cleared well with the CTT. So then you counsel the parents. We've had this enucleated and put in a prosthesis. So remember, this child doesn't need to go to school like this. You can make the child go to school like this. Only the parents and the child knows that there is no eye in the right eye. But this is the same child, so you need to go further beyond the eye also at times. Again, more than the IOP, this 4-month-old baby with no pupil in the left eye. You can see this eye has no pupil. It's actually a condition called achorea, where there is no pupil formed. It's imperforate. And the IOP is 26 with no visible angle structures. And we saw on the UBM that this was actually adhered to the lens. So when you have something like that, the better thing to do is prudence. If you're going to go right in the center, you're going to touch the lens, have a cataract, and then you take out a lens in a growing eye, you're in deep trouble. So all we did was an eccentric pupilloplasty and active patching, and have the vision up to 636 by now. The cornea is clear after the goniotomy. The IP is 18, so we'll just handhold and carry on with there. Just one caveat, is all newborn glaucoma really PCG? We had this problem of why the neonatal glaucoma behaves so differently from the infantile ones, and to our horror, we saw this was a turning point really in our thinking of childhood glaucoma, because we actually, when we did a UBM, we saw a nuclear cataract. And when we started testing them, then they were rubella. So we've done a lot of rubella testing for neonatal glaucoma as yet. And one thing that we learned is that if you have a small eye with glaucoma, then think of rubella. And why that's important is not just academically that you pat yourself on the back and say, I've diagnosed rubella, because these children could be deaf, they could have cardiac defects, which we would never look for if we don't think of rubella. So think of intraocular infections as well when you're dealing with neonatal glaucoma, and not just the pressure. So the cornea didn't clear in the rubella babies. These are neonates who did not have rubella, and you see how their cornea clears. But if you have rubella keratopathy, the corneas remain white. So that's another thing to keep in mind. If your corneas don't clear at all, despite pressure control, then you're probably dealing with a rubella cataract. So to summarize, clinical examination is the hallmark in the management, and so much is unknown. Ensuring good vision is a goal, not just IOP control, and we need to hold these children's hands lifelong. Thank you.
Thank you, Dr. Sushmita, for the excellent talk. And there is absolutely no time. I'm sorry, we are handing over to the next session. And I thank all the speakers for their excellent talks. Thank you very much.